We are now broadcasting. Oh, we've got 2 attendees already. Welcome. Thanks for joining us. This is the fun part for me when people start joining and I can see people that a lot of them I've met, and then some of them I only have met online or seen their names multiple times in these sessions, and it's really cool seeing people come to these.
Yeah, that's very cool. Does anybody want to let us know where you're joining us from in the chat so we can see all the different places that people are signing on from?
And this is Dominga No. She's going to be managing the chat box. She's with us at the Marfan Foundation. And I'll introduce you again at noon, Dominga,
Okay.
when more people are on, but just for the people who are coming on now. Love seeing familiar names here. Great to see you. So we'll give it a few minutes. Right now we've got 6 people in, and I think I know everybody here, or at least I've seen your name at least once. It's very cool. Although I haven't figured out who SH is. Hey, Kelly.
He's just checking in on us, making sure everything's running smooth.
Yep.
You guys good over here?
I think we're good.
Awesome. Have a great day.
You too, Kelly. Thanks.
Give it a few minutes. Trying to upload the chat on my Whova. Do you have to refresh your chat on the Whova app?
Yes, that's why I do it on my second screen. But once you went live, I had to refresh it so I could get that update. Yeah.
Funny. All right.
Technology, it runs a little bit slower than we do.
Yeah, sometimes. Hi, Abby. What an exciting week or couple of weeks this has been so far.
Absolutely. Dr. Frank, is this your first session with us?
Oh, yeah. My colleague, Xenia Geometry, already had one on the 25th of August. But this time is that's the first for me.
Well, welcome. We're happy to have
any other this year.
Okay.
This year.
Well, we're happy to have you.
Well, thank you. Thank you for the invitation.
And Dr. Jim did great too. He was on the 25th with Dr. Morris. That was the ABCs of vets that he did with Dr. Morris. That was
wonderful.
So
that recording is up too, right?
You stole the words right out of my
mouth. I've just, because I've been working on all of these, I haven't had a chance to see them live, so the recordings are great.
Yeah, I think in maybe mid-September, I will be sitting down and hopefully watching all of these. I don't know how long they'll be on the Whova app. I don't know if we've figured that out yet.
Well, I think we're going to keep them up as long as people are needing them. And it seems like that's going to be for a while. So we're going to keep them up for a long time, which is great. Absolutely fantastic.
Good. So any I missed, I will have to go back and watch after this.
Absolutely.
Very crazy busy time. So far, I don't see any messages in the chat.
Nope, but it's also still, I mean, I'm here from Missouri, so it's still a little bit early in the morning, not too early. But then we also have our West Coast family, which, oh, now we have someone. Hi, Misty. Thank you for bearing with us.
I actually know where a lot of these people are, I think, because I know most of the people who are attending right now. So it's
gotcha.
But it's great to see you guys again and again in these. I'm glad that you are enjoying this E3 Summit and getting the most that you can out of it. So really appreciate that. Very cool. I wonder how many people are joining in from France and internationally too.
I wonder. It's been amazing to see so many people from all over the world joining us for these sessions. It's really, it makes you realize how small the world actually is.
It is, yeah, it is pretty small. It's great. I love that.
Absolutely, absolutely. Alrighty.
Oh, I see Hadar's coming. I know her. Hello, Hadar. Good to see you. Don't worry, I can't actually see you. I can only see your name.
I know, I did scare, my younger sister signed up for one of these sessions, and I called her out by saying, "Oh, hi, welcome Sam from Oregon." And she was like, "You can see me?" And I went, no, I promise. You're fine.
I got one of those text messages too at the beginning. On the very first one, they're like, "Oh my God, can you actually see me?"
I was like, "No, everyone.
Nope.
It's okay."
I can imagine what your beautiful face looks like. It's great. Really great to see everybody. So we'll get started in just a minute. We want to wait until the top of the hour so that we're not missing anybody who's just logging on. And I'm sure we'll get more people that log on as we're going. Dr. Frank, we have 23 people right now who have joined us. Very cool.
Absolutely. And hi, Francis. Thank you for joining me in the chat. If it wasn't too much trouble, I feel like it would be great if we had like elevator music playing until we started the session.
I said that yesterday at ours, and I said I need elevator music playing or something, you know, like some welcome music. And I think it was Fran said, "Oh, we don't need to hear music. We love hearing your voice, Katie." And I'm like, "Oh, my heart."
That's very nice.
It was really, really sweet.
I love that.
So it is 12 o'clock now, so I guess we'll go ahead and get started. Welcome, everybody. If you don't know who I am, I'm Katie Wright. I'm the director of the VEDS Movement, a division of the Marfan Foundation, and we're very excited to welcome you back to the International E3 Summit, Educating, Empowering, and Enriching Our Community. This is brought to you by the Marfan Foundation and its divisions, the Loeys-Dietz Syndrome Foundation and the VEDS Movement, and our partners in Europe at the CERN. We are making history, and I don't know if we've had any registrants since yesterday, but yesterday we had 2,680 registrants from 72 countries, which is truly incredible to have people across the world participating in this event. Everything highlighted here in purple is people who have registered for this international summit. And not only do we represent places all over the world, we have lots of people from different conditions, including obviously today, vascular Ehlers-Danlos syndrome. We have 140 people registered who are interested in these vascular Ehlers-Danlos syndrome tracks. We also have over 300 medical professionals who are joining us in this International E3 Summit, and we are extremely honored for that. I did forget to introduce Dominga at the very beginning of this. So Dominga No is joining us from the Marfan Foundation, and she will be managing the chat box. So if you see her in there, she will be managing all those messages. I also would like to introduce Dr. Michael Frank, who is going to prepare a presentation for us, and he will be joining us for the Q&A as well. Dr. Frank, would you like to say hello to everybody?
Of course, yes. Hello to all attendees. I'm very happy to be here tonight on direct from Paris in France.
Very amazing. So we'd also like to thank our presenting sponsors, Brigham and Women's Hospital and American Communications Construction, for helping us bring this international summit to you. And we want to make sure that you know that this International E3 Summit is a forum to provide an open communication of issues related to genetic, aortic, and vascular conditions. As such, opinions stated in each of these talks are those of the speakers and not necessarily those of the Marfan Foundation or the CERN. So if at any time you have questions about this or need clarification about differences in opinions between session speakers, please don't hesitate to contact us. You can do so at marfan.org/E3ask. And that will get you to our Help and Resource Center. We are experiencing a high volume of questions right now, so just be aware that it might take a little bit of time to get back to you, but we will do the best that we can to get back to you promptly, and we value all of your questions. So if you would like to provide us feedback about this session after the presentation is over and after the Q&A is over, you can do so in your Whova app by clicking that rate button, and that will let us know how we did today. And now, before we go on to the presentation, I think Dominga and Dr. Frank and I are going to turn off our videos and audio so that we can focus on the presentation that Dr. Frank prepared. Thank you all so much for joining us, and we will look forward to questions in the Q&A box after this presentation. So I'm going to go ahead and take off my video. And I'm also going to mute myself.
Thank you for the invitation to this presentation. I welcome all attendees that are listening along. I'm a cardiologist and a specialist in vascular medicine, and I am specialized in diagnosis and management of patients with vascular Ehlers-Danlos syndrome in a multidisciplinary expert center in Paris, France. I have a personal experience of 16 years in the care of this disease, so the presentation here will be in part the reflection of my personal experience. At first, a few remarks about this presentation, notably that there is only limited international consensus on how to treat, monitor, and manage patients with vascular Ehlers-Danlos syndrome, and the care and type of monitoring may be different according to countries and types of healthcare systems. We will discuss during this presentation off-label use of medications. The main objectives of this presentation are to define the main milestones in the care of patients with vascular Ehlers-Danlos syndrome following their diagnosis. We will also discuss patient monitoring and the general principles of management of the most common complications of VDS. Due to time limitations, we will not talk about pulmonary complications as well as management of pregnancy and the treatment of varicose veins. A quick reminder or definition of vascular Ehlers-Danlos syndrome. Of course, you know that is caused by pathogenic variants within the COL3A1 gene, and that this mutation is characterized by a dominant negative effect, which means that the product of the mutated allele will interfere with the product of the non-mutated allele, and which will cause, namely for the glycine substitution and the spliced variant, an important deficit of type 3 collagen in connective tissue, approximately of 88%. This is not the case for the variants leading to haploinsufficiency, which result in a 50% deficit only of mature type 3 collagen within connective tissue. The diagnosis of vascular Ehlers-Danlos syndrome requires the identification of a pathogenic variant within the COL3A1 gene. The first step after molecular diagnosis, and it is of significant importance, is to establish a multidisciplinary care team. In some countries, there are designated expert centers readily available, and networks. In Europe, for example, these can be found through the VASC-ERN phone application. These multidisciplinary care teams do have a core team of physicians composed by cardiologists, specialists in vascular medicine, vascular surgeons, geneticists, psychologists, and there should be a second line of specialists that would be available on demand according to various situations or complications that might occur. And these teams should provide or coordinate the molecular diagnosis, if possible, the emergency care, and the patient follow-up, as well as family screening. The second step of patient management is to design an individual care plan adapted to each patient. This encompasses emergency passports, alert bracelets, eventually phone applications, modalities of access in case of emergency, psychological support whenever necessary, and the organization of the monitoring and clinical follow-up of the disease. Physical activities can also be discussed at this point, which mainly consist in avoidance of collision sports and isometric activities, and pregnancy can also be discussed at this point when applicable. I'll take a few moments to go back to the natural history of vascular Ehlers-Danlos syndrome. It has been evidenced that the disease would become clinically active in the late teenage years or during the early adulthood, and that these complications would recur unpredictably at a median rate of 1.6 events per 5 years in our population. The types of complications are predominantly arterial, of course, followed by colonic perforations. There are significant factors that influence these outcomes and that may also affect monitoring or surveillance, which are gender, with a defavorable effect of male gender, the index or relative status within one family, and the type of genetic variant the patient may have. Because of this age dependency of the clinical expression of vascular EDS, one can consider 3 lifetime periods, and that would be childhood or early childhood, that would be typically free of events, in which organ complications are extremely rare and often triggered by intervention. Then we have the teenage years, during which events may start to occur, particularly arterial rupture in young men, as well as pneumothorax and sigmoid colon rupture. And we have then the adult life, which is considered as the clinically active phase of the disease, and the onset of which is variable. Having defined these 3 different periods in the life of patients, we can go back to the monitoring and patient surveillance. At the moment of diagnosis, an initial evaluation of the arterial tree is commonly done, but depends on the circumstances of referral and of the age at which the molecular diagnosis is done. Findings will not be the same for a symptomatic patient that has been referred for diagnostic workup and in which a COL3A1 mutation is identified, than in relatives that are non-symptomatic and that have never had a clinical complication that would be carrier of the same mutation. In symptomatic patients or index patients, the initial evaluation very frequently identifies several other arterial defects for which the patient hasn't been referred for. This first evaluation is important because it helps to determine the state of progression and is also a reflection of the potential severity of the disease and can serve as a baseline in case of future events. So what exactly is monitored in patients with VDS? It's mainly the target arteries of the disease that would be the medium-sized arteries, which are present in numerous parts of the human body, and of course the ascending and descending, as well as abdominal aorta. The intervals between monitoring are adapted individually and should be taken into account the medical history of the patient, the fact that he's a symptomatic index patient or a non-symptomatic relative, and of course according to the type of genetic mutation that has been identified. The monitoring is associated with episodic outpatient visits to check on the patient's well-being and on his tolerance and adherence of drug prescription. The range, the intervals at which the arteries would be monitored would be between 1 and 2 years, but is always adapted individually. Of course, the fact that arteries are monitored does not exclude the possibility of the occurrence of an arterial rupture even 1 or 2 days after monitoring. Now we have a slide on the different examinations that are possible for arterial monitoring in VDS patients. All of these examinations have their advantages and disadvantages. They may be used all together or used sequentially, or partially be associated in the monitoring of arteries and of the heart in VDS patients. Other situations that require monitoring are, of course, acute arterial events by any means, at any necessary rate. After acute arterial events, with the monitoring at 1, 3, and 6 months, and that would depend on the type and the location of the accidents that have occurred. And for any other event that is non-arterial, particularly if there has been important stress involved for the patient, that means stays in the ICU, surgery, mainly abdominal, important blood loss, and a prolonged hospital stay. These timing are also adapted to each particular situation and have a span from 0.5 to 3 months after hospital release. There are other situations in which monitoring may be discussed, and that would be non-symptomatic children in which the disease is clinically silent. It is apparent that monitoring is of no utility, of no benefit for the children, and at least at our center we do avoid monitoring children of this age. In asymptomatic teenagers, it's probably justified to initiate monitoring at some point, particularly because of the increased risk of arterial ruptures in young men during this period. The technique of choice would be duplex ultrasound because it is harmless and easily available. We now come to the second part of this presentation, which is on treatment of organ complications of vascular EDS. We'll start with arterial accidents, which are the most common and characteristic manifestation of this condition. These occur unpredictably at a median 1.3 events per 5 years. The most common defect would be an arterial dissection, and they would touch medium-sized arteries, but aorta as well. Arterial accidents should be suspected in case of occurrence of any acute pain, particularly located at the eye, at the chest, at the abdomen, and at the limbs. And the two latter, arterial accidents, are often associated with swelling and might indicate a dissection or arterial rupture. All these different locations or acute pains should have the patient seek immediate medical attention to decide whether a CT scan should be performed emergently to detect arterial rupture. Once the nature of the arterial complication is identified, usually great majority will be treated medically. The principles of medical treatment of these arterial accidents are blood pressure control associated with heart rate control, pain control, and anxiolysis. Body fluid or perfusion volumes should be limited, as well as the use of inotropic agents, in order to avoid supplemental stress on the arteries and to avoid secondary dissections to the primary accident which motivated the hospitalization. Sometimes, in case of acute limb ischemia, for example, antiplatelet agents may be prescribed transiently, or even anticoagulant agents. Thrombolysis seems to be very frequently associated with bleeding accidents in VDS patients and should therefore be avoided. When invasive therapy is necessary, in case of arterial rupture, for example, percutaneous coil embolization should always be preferred over stent placement. However, stents can be used in case of arterial rupture in order to stop bleeding or important bleeding quickly, and in order to avoid invasive or likely complicated surgery in an emergency setting. Reconstructive surgery is possible and should be elective and discussed in a multidisciplinary setting, and considered particularly for young patients with a favorable medical history or surgical history, and in patients with haploinsufficiency. All invasive procedures should be performed in an in-hospital setting with a vascular surgery standby close by. The second most frequent complication of vascular EDS is colonic perforations. This affects almost 1/4 of patients with vascular EDS, and the symptoms of rupture will associate fever, intense abdominal pain, nausea and vomiting, and others, and all of these will have the patient to seek immediate medical attention for urgent treatment. This treatment associates antibiotics and very often surgery to clean the abdominal cavity and to remove the ruptured segment of the colon. During surgery, simple repair has been associated with high rates of reperforation and should therefore be avoided. Usually a Hartmann's procedure would be preferred or performed, and with a secondary reversal. Despite this precautionary technique, there's a high rate of reperforation or anastomotic leaks, even in the Hartmann's procedure, almost 1 patient in 2, and this seems to be happening particularly in male patients. So in some situation it might be discussed to make a subtotal colectomy to prevent the occurrence of reperforation. Of course, colonoscopy should be avoided, especially in a postoperative setting, and constipation is frequently associated with rupture and should be treated aggressively. We now come to the third part of this presentation, which is the medical prevention of arterial complication and the reduction of morbidity and mortality. There is only one clinical trial that has formally addressed this problem in vascular Ehlers-Danlos syndrome, published in 2010 and called the BEVAS trial. During this multicentric international trial, a drug called celiprolol, which is a cardioselective beta blocker with beta-2 adrenoreceptor agonist action and NO release, has been tried against no treatment in patients with a clinical diagnosis of vascular Ehlers-Danlos syndrome. The patients were either assigned to this treatment of celiprolol or no treatment over a 5-year period. 53 patients were enrolled into the trial. 25 were allocated to celiprolol and 28 to control or no treatment. And if we look at the survival according to the primary endpoint, meaning the event-free survival without cardiac or arterial event related to vascular Ehlers-Danlos syndrome, we see a major protection provided by celiprolol with a 64% risk reduction in patients taking this drug. If we look at the secondary endpoints, which was any non-cardiovascular VDS-related event, patients taking celiprolol still had 69% risk reduction. And if we take both endpoints altogether, the protection was even greater, with a 75% risk reduction in VDS patients taking celiprolol versus no treatment. The conclusion of this trial was that celiprolol was effective in preventing cardiovascular complications in patients with vascular EDS in comparison to patients taking no treatment at all, and also that this treatment was well tolerated at its target dose of 400 milligrams per day in most patients. There are technical issues to this study, notably the absence of a placebo, that the study was not double-blinded, and that the genetic test confirming the presence of a mutation within COL3A1 was not mandatory at inclusion. And finally, that the number of patients that were included is quite small, which is due to the rare nature of vascular EDS. So to further study the protective effect of celiprolol, we analyzed the population followed at our institution, and these data were published last year. That totaled 144 patients that were followed over a period of almost 20 years at our center. These patients were systematically screened, monitored, and of course any event that occurred was recorded. If we look at the overall survival of this cohort, it was rather good and higher than expected, with an overall survival of 71.6% of our patients, with only 17 patients that passed away, with 14 deaths directly due to vascular EDS, and 3 non-vascular EDS related deaths. We looked then in patients with the more severe forms of vascular EDS, which are the glycine substitution and the splice site variants, the effect of taking celiprolol versus taking something else, or taking celiprolol inconstantly. And we see in the left figure that there is a significant difference in outcome in patients taking celiprolol versus taking no treatment or another treatment than celiprolol. We also identified a dose effect, meaning that the cardiovascular protection was less effective in patients taking less than 400 milligrams per day than patients taking 400 milligrams per day. We also looked at the effect of celiprolol on the occurrence of acute arterial accidents by looking at the total number of hospitalizations for acute arterial events at our institution before and after the prescription of celiprolol. You see here with the black dot, the black arrow, the end of the BEBAS trial, and the moment where all our patients were switched to celiprolol with a systematic prescription, which was not the case before. And you can see in the red curve an inflection, a stabilization of the total number of hospitalizations, despite a constant increase in patients followed at our center, which are indicated with the dark blue line. You can also see that the hospitalization index, which is shown in gray, is stabilizing, which indicating also a reduction in hospitalizations for acute arterial accidents. So these data also indicate a protective effect of celiprolol. There certainly also is a supplemental protection that is offered by coordinated care in a dedicated expert center. Following these results, celiprolol has become the standard therapy for several centers in Europe, but not everywhere. Of course, patients are being treated also with other beta blockers and anti-hypertensive drugs according to local expertise, possibly with good results, but these drugs have never been tested in vascular EDS since the BEBAS trial is the only trial that has ever been performed. That means that many further clinical research is necessary, and that researchers need to remain motivated, that patients have to be motivated also to participate to these trials, because this would be the only way to further improve the management and treatment and ultimately the prognosis of vascular EDS. I thank you very much for your attention, and I think we will now have some Q&A session, and I will be very happy to answer to your questions.
Thank you, Dr. Frank, for preparing that presentation. We will move on to the Q&A now. So let's get Dr. Frank back on. Oh, good. He's already on. Great. Thank you so much, Dr. Frank, for preparing that. And we did have some questions come into the Q&A. So if you have a question and you have not submitted it to the Q&A box, please feel free to do so now. I'm monitoring the Q&A box and I will be reading your questions to Dr. Frank. All right. So our first question, and I think you mentioned this a little bit in the presentation, but maybe you could elaborate on it. How essential is it to have regular scans? They've been told by the cardiologist that even if they find something, nothing will be done because it's too risky. And they're just curious, you know, what your take on it is.
Well, there's two sides to monitoring. There is an interest for an expert center or for the community of patients to gather information on the natural history of the disease. That helps us to better know what's happening and how to treat. There is not always a direct benefit of doing CAT scan surveillance for the patient because as the question was mentioned, nothing's going to be done either way. However, there are 99% of situations where nothing will be done or has to be done. And there are a few situations in which you might discover a lesion that has appeared or that is progressing rapidly and that might need some intervention. So these are the main points. We have also noticed or noted in our population that 20% of patients between two monitoring or CAT scan or duplex ultrasound examinations that are apart by 1.5 years approximately, 20% of patients will evolve. Means we'll be having novel arterial lesions, dissections that are completely clinically silent and that would not have been detected otherwise.
Thank you. Thank you for that clarification. I know that's a tough topic because so many of us do get these scans and then don't have anything done, but it is important. So what is the ideal blood pressure measurement if you have VEDS?
Well, most of the VDS patients have a normal blood pressure. It certainly has to be treated aggressively, would be arterial hypertension. If present, and that may happen if you have renal infarction secondary to renal artery dissection, and that would have to be strictly controlled. Usually patients very often with VDS only have 100 to 110 millimeters of mercury of blood pressure, of systolic blood pressure, so it's really not very high. That would have to be respected, and I don't think that taking it lower than that would be beneficial in any way.
Okay, thank you. So the next question is about a blood thinner, Coumadin. Is Coumadin dangerous to be on for VEDS patients?
I think Coumadin is dangerous for any patient that is on Coumadin. In France, we have 5,000 deaths because of Coumadin and only 200,000 people taking it. That means that there's more deaths by this medication than the road accidents. That's a very huge number. So I think Coumadin is a very high risk in any patient, and more particularly in VDS. However, for some situations, you would have to have this medication prescribed, for example, for a pulmonary embolism. It is sometimes necessary, and it should be transigned and removed as quickly as possible. So the prescribing physician eventually should keep in mind to withdraw this treatment as fast as possible, if it's possible to withdraw it.
Thank you. And let's see, we've got a lot of good questions coming in. I really appreciate everybody using the Q&A box. What medical examinations are recommended for annual surveillance for VEDS?
It strongly depends on your healthcare insurance. I think in the United States, maybe I'm wrong, but it's maybe sometimes the insurance that decides what type of examinations you're going to get. We have here in Europe, in our center, what is standard for these monitorings is that patients get MRA or CTA of the neck, brain, neck, and abdomen. And plus, they get a duplex ultrasound also from the neck arteries for the abdomen, so the aorta and its branches, as well as the lower limbs. So we also get echocardiography episodically. So we have that possibility. We have no limitations in whatever examinations the patient is getting. We can prescribe and the patient gets it. So that's what we do here, but it's not necessarily the thing you have to do anywhere in the world.
Thank you. Okay, so our next question is about celiprolol, which you talked about. Since celiprolol is not available in the United States, would nebivolol or bisoprolol or both cardioselective beta blockers be advised for VADS? What would you do for a patient who does not have access to celiprolol?
Yeah, that's complicated. The BEBUS trial was re-examined by the FDA because an American company was trying to get it to the United States. And the data I've presented to you were deemed not sufficient for the FDA to allow the prescription of celiprolol in the United States. I think it's difficult to recommend a specific drug because there is no equivalent to celiprolol. I would say that nebivolol would be also has a vasodilatory effect, and that it is probably a mild equivalent of celiprolol. That might be interesting. Bisoprolol doesn't have at all the effect celiprolol has, and has a stronger effect on heart rate, which celiprolol doesn't have at all or hardly ever has. But if you don't have any other possibility, I mean, that would be an option. But it's very difficult to tell you if bisoprolol is equivalent to celiprolol, or if nebivolol would be equivalent to bisoprolol. I wouldn't be able to answer that question.
So that really goes back to our need for many more clinical studies, like you mentioned.
Yeah, well, of course, and you see that is very, very difficult to do. The BEBUS trial had 53 patients, so it's a very small number. We have just finished another clinical trial here for medication in vascular EDS, and we were hoping to include about 100 patients, but we managed to include only about 70 patients. So you see, it's very, very complicated. And at each trial you make, at each approval you make in the prognosis of the disease, patients also get the or lose some the benefit or the sense of emergency to participate, because they gain protection by the treatment that is given to them. So it makes things a little bit harder each time you make one.
Thank you very much for providing that clarification. So for someone whose cardiothoracic surgeon has determined that they need their 14-year-old metal heart valve replaced and wants to do a heart catheterization, what precautions should be taken during that catheterization for someone with VADS?
So this will not be open surgery, is that correct?
It sounds like it's going to be a catheter procedure.
Okay, I think for these kind of procedures, for the mitral valve, I think would be the most important would be the surveillance or the extreme caution on the groin, where the catheter will most likely be inserted, and on the whole trajectory of the guide wire that goes up through the iliac artery and the aorta. And I think that should be the thing post-operatively that would have to be needs the most surveillance, because that would be, I think that the mitral valve replacements requires quite a big insertion, and so that would put a lot of stress on the femoral arteries and all the arteries this device would go through. So my main concern would be the groin and the iliac arteries.
Thank you. And have you seen any patients with VEDS and bicuspid aortic valve? And if so, have you noticed whether or not they have complications earlier than somebody who does not have a bicuspid aortic valve?
I think it's definitely possible to have bicuspid aortic valve because it's quite frequent. I'm not sure we have a patient with VEDS and bicuspid aortic valve, maybe one. But I wouldn't say that there should be more or more complications because of the bicuspid. The main concern would be the ascending aorta, because if you have a narrowing of the valve, probably the ascending aorta would be put under much stress or too much stress for that it can't withstand. So I think it would maybe give a faster progression of an aortic aneurysm. I hope this helps.
Thank you. Our next question involves emergency room care and treatment. So if a patient with VEDS presents to the emergency room or the emergency department with abdominal pain and scans show a lot of stool and constipation, would you recommend that person be sent home or in some kind of home treatment or hospitalized on fluids? What would you recommend in that kind of situation? Is that within your realm?
Well, if that would be happening here, the patient would certainly be hospitalized in our department, and he would get adequate monitoring to see why he has abdominal pain. If it's an ileus or if it's something else, and if it's just constipation, which is unlikely to just have constipation that is giving intense abdominal pain, it would be treated. So we would hospitalize this kind of patient, of course we would.
So that patient with constipation would be treated at the hospital?
Well, in the initial phase, until we know that there is nothing else, and until we know why he has this abdominal pain. Yes, you can have gastroparesia in vascular EDS, some sort of a paresis of the transit or the stomach and the colon, and this might be the cause in this particular situation if it's only constipation.
Thank you. And we did have a couple of GI sessions on gastrointestinal issues and VEDS. So if you missed those, go back to the Whova app and look for those recordings. We had a wonderful gastrointestinal surgeon and a gastrointestinal physician giving those sessions as well. So if you have further questions about those, I think that would be a great place to also get some information. Would a vertebral dissection that healed on its own and happened 10 years ago, could that still cause neck pain residually?
Yeah, that's difficult to answer. Usually, vertebral dissection may be symptomatic for several weeks or months, meaning having neck pain because of this. I wouldn't see, I don't have the experience that patients have chronic pain because of a dissection that has healed. I wouldn't see why that would be a causative in this situation specifically.
If somebody is allergic to beta blockers, what alternatives would you or could you recommend?
Yeah, for people that are intolerant to beta blockers, you could either maybe use alternatively an ARB, angiotensin receptor blocker, which are common medications used in hypertension, and which we are actually studying in the second clinical trial we've been doing. And this might be an interesting alternative. And if there's hypertension or if there is a need for heart rate lowering medication, you have calcium channel blockers that are just good to do that.
Okay, thank you. And we've got a lot of great questions here, so we will continue to ask questions until we either have no more or we have no more time. So can vascular Ehlers-Danlos syndrome cause angina? And if so, how do you differentiate between angina and a dissection?
You mean chest pain, cardiac chest pain, angina?
Yes.
Is that correct? Well, it certainly is possible to have angina because of a coronary artery dissection. That certainly is possible. Peter Byers has described these in the populations he has published. We here in our experience, we don't have that so much. We don't have many acute coronary dissections. How to identify a cardiac pain? I mean, this is relatively typical compression on the chest that might irradiate to the neck or to the left shoulder or forearm would be very evocative of such a problem. That's a typical cardiac pain, but then it can be totally absent or different. It depends of your comorbidities eventually, if you have diabetes or not. I hope this answers somewhat the question.
I think what I think I heard is that it can be very similar, or the angina could be caused by a dissection. So maybe it'd be difficult to differentiate without surveillance. Yeah,
but of course, if you suspect that there is a cardiac or coronary problem, you would do the appropriate imaging to see what's happening. And if you do the imaging, you would see if there is a dissection or a problem on the coronary arteries or not. So, I mean, we have the examinations to know exactly what's going on.
Okay.
So we would do that, of course.
Thank you. Okay, so this one is actually about COVID-19. In the case of severe COVID-19, the standard intensive care procedure includes anticoagulants. Do you know or have any experience on whether or not that can be used still with patients with beds who are very sick with COVID-19?
Yeah, well, it has been evidenced, I think that was even at least in part here in this hospital, that there was a prothrombotic effect of COVID infections in the severe cases with high risk of microthrombosis. And this should be and can be in VDS prevented with anticoagulant therapy that is transient. And I think it is necessary if it's indicated by the doctors in the ICU. I would definitely recommend this for further or better protection of the patient. This would only last a few days anyhow.
Okay, and for anybody who's here that is not familiar with the word thrombosis, could you describe what that means?
Well, that would be a clot formation in the vessels that could be either a big vessel or small vessels. It has also been observed or described within arteries or distal arteries in these severe COVID-19 cases. So it could be arterial or venous.
Thank you. Okay, a lot of great questions here. Thank you everybody for submitting your questions for Dr. Frank. So I've had a right renal artery dissection last year and had a large infarction. Managing blood pressure with an enalapril and aspirin because they suspected fibromuscular dysplasia. Am I still at risk of other complications?
The person was asking if she's still at risk of other complications?
Yes.
Secondary to what? To aspirin, to vascular EDS, or both?
I would say probably both. It's not 100% clear, but they had an renal artery dissection with infarction that is being managed with blood pressure medication and aspirin.
Sure. Well, I don't have, this is a specific situation, so I'll try to answer as good as I can. The antihypertensive medication is imperative in case of renal infarction because there is a risk of renal vascular hypertension that is secondary to the ischemia. So this is the most important part of the treatment to prevent any other arterial accidents caused by or precipitated by hypertension. The prescription of antiplatelet agents would be, in our experience, only be transient unless there would be something or a specific indication to have a long, to have aspirin on the long run, because the benefit of this fluidification of the blood, I think, vanishes quickly after maybe a few months, maybe 1 year, and you're getting into the risk zone, and you will maybe spend many years without having any problem. But the day you experience a problem, meaning a bleeding somewhere, of course, aspirin would precipitate you maybe in a more severe situation than you would want to be in. And that's why we are very cautious on the prescription, on the long-term prescription of aspirin in these patients, and we try to remove it as fast as possible.
Thank you. I hope that answered your question. For the person who asked that question, if it did not, feel free to submit that question to our Help and Resource Center at marfan.org/E3ask. And that link will be up at the end of this presentation as well, but then we can get a more specific answer to your question or work on getting you connected with a knowledgeable physician. Let's see. Have you ever seen a case of spontaneous aneurysm regression in someone with VEDS?
Yeah, we have seen that. We have. I'm convinced that VDS patients have great healing capacities, and what is happening is that dissections heal, and those that are the most spectacular to heal are dissections of arteries of the forearm. That would be the radial and ulnar arteries. They could be completely dissected, eventually occluded. Or you could have aneurysm formation, and these lesions, to our great surprise, regressed totally and did not leave any sequelae that was visible through imaging. So that's possible, yes, of course.
Okay. And our next question, I think, is, and I'm going to shorten this question, I think. So in your, let me figure out a way to word this. Are you still following patients with VEDS who have a non-glycine missense variant in the triple helix at your hospital?
We have some of patients with these variants, but we have evidence in one of our papers that these patients were also prone to some form of arterial fragility, but that there was much milder than haploinsufficient patients. So we don't follow them specifically. If they request that we follow them, we would eventually, but these patients are being sent back to a normal follow-up to their regular physicians. Yeah, we don't systematically see them again.
Thank you for clarifying that, and I hope I answered that, or asked that question in the right way, and hope that we answered your question. Is catheterization always contraindicated for VEDS, or can dangerous arrhythmias be treated by ablation? Is that risk too high? I think we sort of answered this question, but if you could clarify that again, I think that would be great.
Well, in VDS, nothing is really impossible. It's just a balance of risk and benefit for the patient. And the less you have to be invasive, the less chances you take to have adverse events. That's the general rule. And if there needs to be an invasive procedure, it has to be done with physicians that know the inherent fragility of VDS, which is not always the case. Very often, vascular EDS is confused with EDS. It becomes EDS, or so. I'm not sure that there are a lot of physicians out there that have really a significant experience in manipulating these arteries or in catheterization. So if it's necessary, it's always possible. But then you have to make sure that the physicians that do this are totally aware of what they're about to do. And maybe they could discuss it with the colleagues of their respective networks that that have knowledge of vascular EDS to determine the best type of procedure and to confirm that it's necessary.
Thank you. And if if you are treating somebody at, let's say where you are, where celiprolol is available, how old do you usually start BEDS patients on celiprolol? Like at what age?
We would start the treatment during the teenage years. Here in Europe or in France, for instance, we don't, we diagnose molecularly children that are clinically silent from between 10 and 13 years of age, not before. We don't diagnose children under 10 unless they're symptomatic. If something happens, of course, there's no problem. Once we do this, we associate this diagnostic procedure with the initiation of celiprolol, meaning that we would try to initiate this, let's say at the age of 13 years, to maybe cover better the high-risk period this age represents, particularly for young men. So I say 13 to 15 years.
Okay, thank you. And for someone with BEDS who has arterial stenosis, how would you treat or manage that?
Well, it depends on the cause of the stenosis. In VDS, usually stenosis is secondary to dissection, which means it's part of the arterial wall that would occlude or be an obstacle to the normal blood flow. In this case, in most cases, we don't have to do anything because the dissection would heal out by itself. The problem can persist if the stenosis is persistent, and then we would have to eventually discuss some treatment. If the stenosis is of an atherosclerotic nature, that means if there is a cholesterol that is occluding the artery, the treatment would depend on the location of the stenosis. If it's coronary or if it's on an iliac artery, the treatment will not be the same. So my question back would be, where is that stenosis? And is it atherosclerotic? Is it cholesterol, or is it a dissection?
So it depends.
Yeah, it depends on the cause.
Thank you very much. For someone who is, and I'm very sorry for this person, their 34-year-old daughter passed away recently from a ruptured aortic dissection. So I'm very, very sorry for your loss. Their 30-year-old daughter, who was also diagnosed with BEDS, is asymptomatic. What kind of surveillance do you recommend for patients who are asymptomatic?
Yeah, that's an interesting illustration of the heterogeneity of the expression of this condition. Since in this family, both children have the same mutation, but the outcomes are obviously different. I would say at diagnosis at the age of 30, I would do an arterial assessment to see what arteries are dissected or if there are aneurysms. And according to this, I would put her on treatment and to try to protect her from particularly aortic dissection, and recommend some monitoring every 1.5 years, probably in this case.
Thank you. Could you clarify the long-term aspirin discussion that we had earlier? Is long-term aspirin not ideal to be on in case of another dissection or rupture? Is that what you were saying?
Yes, absolutely. Okay. It's absolutely it's not an ideal situation to have a long-term patient on aspirin. The other question that comes with it is, why is it prescribed? If you have had some bypass surgery or endograft or stent that absolutely needs aspirin, you can't withdraw it, and you just have to go with the risk, because if you withdraw the aspirin, you would have a complication that is secondary to the thrombosis or clotting of the device that has been put there. If it's being prescribed just because there has been a dissection, even let's say with a renal infarction, there is no indication, in my perspective, to keep that treatment on the long term.
Okay, thank you for clarifying that.
Just one compliment to that. if you would have, let's say, a transient ischemic attack because of a dissection or a persistent dissection, and if you, that would be treated with antiplatelet agents. If you have a relapse, or if it happens again once you withdraw aspirin, of course you would have to prescribe it, and you would have to keep this drug because you don't want your patient to have a stroke. So you see, there are different, always two sides to the coin. So there are some situations where you have to have it. That's your physicians will decide eventually if that's the case or not. But if it's not absolutely necessary, it should be as short as possible.
Great, thank you. And I think we're reaching our last question. Do you know if patients with VEDS have a higher prevalence of bleeding disorders? And do you test newly diagnosed patients with VEDS for bleeding disorders?
Well, we're in the process of analyzing this. We don't have the personal experience of bleeding disorders. This means that all the patients that we have operated do not systematically have hemorrhagic complications or don't get any substitution or treatment like desmopressin during procedures to prevent any serious bleeding. There has been a paper that has published something, data that suggested that there is an abnormal platelet function, but we could not confirm that in our clinical practice. So there certainly is a tendency to have bruising, to fragility. There is a tendency in vascular ADS to have more bleeding than patients that have no connective tissue disorder, and that is also has to be taken into account during any surgery or vascular surgery, that even if you can repair an artery or make a bypass, maybe a surgery, you have to think of the post-operative period, because these patients would have a tendency to bleed more after the intervention than patients that do have no connective tissue. And I guess that, I believe that in Marfan syndrome, that's a little bit the same. All these connective tissues have a higher tendency to bleeding following invasive procedures.
Thank you. And thank you so much for your time tonight, or today, depending on where you are. I know it's tonight for you, it's today for me. So thank you so much for your time today. I know that we all really appreciate it. If your question was not answered today, please feel free to submit them to marfan.org/E3Ask. That will get you to our Help and Resource Center. And a reminder again that our Help and Resource Center is getting a lot of questions at this time. So, just expect a little bit longer time to answer than what we can normally do, but we will get to your question. If you could complete the session survey in the Whova app, we would really appreciate it. And there are a ton of things for you to do in the Whova app, including connecting with community and the other sessions that we have planned over the next week and a half still of this very amazing International E3 Summit. I did receive an update during this presentation that we have exceeded 2,700 people across the world who are enrolled. So I think it's 2,706, which is truly incredible and makes us feel really good that we're able to provide this summit to people across the world. So thank you so much for joining us. Feel free to share your experience here or things that you learned using the hashtag E3Summit20. And you can help us make more programming possible by going to marfan.org/donate. Thank you everybody again for joining us. And thank you so much again, Dr. Frank. It was wonderful to meet you, and thank you for providing your time and expertise to this community.
Thanks for having me. Have a great evening, day, or afternoon.
Thank you. And everybody have a great one. See you later.
Bye bye. Quel charmeur.